All right, we're going to have some people probably joining us a little late, but we're going to get started. I just want to welcome everybody. Thank you for attending our Tackling Varicose Veins webinar. As you all know, we are experts at varicose and spider vein treatments here. Dr. Manjoney, she's our owner, operator, and on-site medical director. We've been around for over 18 years. Prior to opening this business, she was a cardio and thoracic surgeon. So she is a recognized leader in the vein treatment industry. So as you probably a lot of you know, she is the gal to see. She obviously not only has a passion for treating varicose veins and spider veins, but she also has a passion to educate her patients, and that's why we're here today. So I'm going to turn over to Dr. Manjoney. Before we do that, though, I do want to remind everybody, at the bottom of your screen, you're going to see a chat button. If you have any questions throughout the webinar, you can type your questions in there. You're all going to be muted, so you won't be able to speak. It'd be a little bit too much chaotic nature if we had everybody talking at once, but we're going to have you ask your questions in the chat. You might see a Q&A button on there. Avoid that one, just do the chat, and that way we can address the questions either during the presentation. If not, we'll make sure to ask those questions to Dr. Manjoney at the end. So without further ado, Dr. Manjoney, I'm going to turn it over to you.
Thank you very much, Tiffany, and welcome everybody. Thanks for taking time out to listen to this presentation tonight, and hopefully we will be able to answer all the questions that you might have. So tackling varicose veins with modern techniques, that's the topic of our presentation tonight. And I am Deborah Manjoney, and I guess we will get started. So I'm just going to tell you a little bit about what we're going to be talking about tonight. I'm going to be talking about the incidence of venous disease, the veins of the legs, what normal vein function is. And then I'm going to briefly talk about deep venous thrombosis. And then we'll talk mainly about superficial vein disease because that's the usual cause of varicose veins. So we'll be talking about what kinds of things you might see and feel. And then we'll talk about the evaluation that is done in our office, what the treatment options are, what insurance coverage is like, and then the procedures we do here. Then we'll show you several before and after photos so you can see for yourself what kind of things we can achieve. And then we will have plenty of time for questions and answers. So there are estimated to be about 40 million people in America who have varicose vein disease. And disease of the veins in the legs is very common. It's a little bit more common in women than in men. It's estimated that about 35% of women and 25% of men have varicose vein disease. And as we get older, things get worse. So in men, after age 50 or 60, it tends to be much worse. And age is one of the primary causes of varicose veins in men, whereas women get them at a much earlier age and can actually start to even see some development of vein problems in their teens and 20s. So again, talking about the veins of the leg first, we have deep veins, which are veins that are underneath the muscle, and they are the important emptying veins of the leg. Then superficial veins are between the muscle and the skin, and that's a network of collecting veins that drain the skin and the soft tissue. There are what we call trunk veins, which are lengthwise veins. They run kind of along the same axial position as your bones in your legs, and they are the great saphenous vein that's on the inside of your leg from your ankle to your groin, and then the small saphenous vein from the heel to the crease of your knee on the back of your leg. Then at the tops of those points, they enter into the deep vein system, and so the deep veins then continue to drain up into the pelvis through iliac veins into the inferior vena cava, which is the main vein in the body, and back up to the heart. Now, besides the trunk veins, there are tributaries, which are basically what we call branches, but in veins, they're called tributaries. And there are reticular veins, which are the little blue veins that you kind of see sometimes under your skin, and spider veins, which are tiny red or purple scratchy veins that might look like a tree or look like a spider on your leg. Those are the very superficial veins that are just under the skin. And then we have a system of perforator veins, which are the connections all up and down your leg between the deep veins underneath your muscles and the superficial vein trunks and the superficial veins, which we've been talking about. And this is just a diagram that kind of shows that these darker vessels here are the superficial veins, and then the more purple vessels are the deep veins underneath the muscle. and it just kind of shows what their orientation is. And then if we do a cutaway, you can actually see deep veins are between the heads of the muscles. Here's the femoral vein, which is a deep vein. This is the perforator vein, which connects to the superficial vein. This is a superficial vein that's not right next to the skin, but is just above the muscle and kind of under your fatty layers. And then the more superficial branches or tributaries that become the varicose veins that we actually see bulging in our legs. What I like to tell people is think of the system of the veins in the leg, the femoral vein, meaning the deep veins, and the superficial veins as like the two stringers on a ladder. And then the perforator veins are the rungs that connect. So they go up and down the leg. They're perforators every several inches, but the main connections are into the top at the groin for the great saphenous vein or behind the knee for the small saphenous vein. And very important is because these deep veins are between the muscle bellies of the leg, when the muscles contract, when you walk with a flat shoe, so you're actually contracting your calf muscles, what's happening is the muscles in the calf become the second heart. So the heart actually pumps arterial blood or oxygenated blood to all the organs of the body and to your extremities. The calf muscles in the leg act as a second heart to get the blood that's furthest away back up to the heart. So as you contract your muscles in your calf, that's the best thing you can do to empty your legs because you're actually activating that pump. It allows the valves to open to let blood go up because there are valves in the veins which will prevent gravity from holding the blood in your legs. So the veins carry the used blood after oxygen has been removed, and they have these little delicate valves that open and close to let the blood go up and prevent blood from being held in the leg or pulled back down by gravity. If veins are not working properly, abnormal veins are called, that's pathology. And vein pathology in the deep veins is either an obstruction or a problem with valve disease. And deep venous thrombosis is the most important problem with deep veins in the legs. And this is a thrombus, is a clot. We can see this is just a diagrammatic illustration of a clot that may be forming in a vein, and it can prevent the valves from closing, but it can also totally obstruct the path of blood that's trying to get through the vein and back up to the heart. And when that happens, we can have obstruction causing swelling and inflammation below that site of blockage. So the blood flow, usually as this diagram on the left shows in a normal leg, the blood flow goes up to the heart and lungs. When you've got a venous clot obstructing, the lower leg gets very swollen because there's no way to adequately drain that blood out of the leg to go back to the heart. And this is the kind of thing that you might see with deep venous thrombosis. The leg that's on your left, which is the patient's right leg, because we're looking at him, that's very swollen compared to the other leg. Deep venous thrombosis can also be very painful. So if we talk about these veins again, they are two separate and unequal systems. The deep veins are the important draining veins of the leg. They drain about 90% of the blood from the legs back to the heart. If the veins are damaged, there's often nothing that we can do to improve them. There have been some attempts to do artificial valves and transplant valves, at least at the top of the leg if necessary, but usually there's nothing that can be done if the valves in the vein are damaged because of deep venous thrombosis. And deep venous thrombosis is very important because it's the source of the majority of unexpected hospital deaths from either chronic illness and people in the hospital for medical problems or cancer, or because of a post-surgical problem. Now, the superficial system, which we're talking about as the main problem that causes varicose veins, has a very minor role in draining the legs. However, if they're not working, then these vessels can dilate and allow blood to pool in the legs, and that causes obstruction of any of the blood vessels that are trying to drain into them, and those are the blood vessels that become varicose. And superficial system is the major cause of vein symptoms in the leg. So the vein pathology of the superficial veins includes both valvular reflux, which means that we are allowing blood to go backwards through a valve that's not working, or obstruction from a clot. And this just shows, again, these valves inside the vein. The blood moves up toward the heart in a healthy vein. And then when the valves close, the blood is stopped from going back down further in the leg. But when you have damaged valves, the blood flow is allowed to go backwards, and that's called reflux. Now, this is just a demonstration of what the well-functioning vein is on your left and the varicose vein on the right. And you can see that the blood is just not flowing normally in that varicose segment. And so this is what can be a cause of clotting in and of itself, because we don't have a nice laminar flow. There's not a good flow as though it's going through a hose, it's going through a kinked hose. And so as you see, blood can slow down and then clot can form in that segment. When that happens, it can lead to a very painful complication called phlebitis. It's interesting that varicose veins really are more of a problem in civilized societies, that it's a Western type of disease. It's not usually seen in people who walk around and do a lot of their activity on foot, but it is very common in people who have sedentary lifestyles and those of us who now drive cars instead of walking to get places. But there's a real gamut of what can be seen in varicose vein disease. The veins may not be visible, as we see in the first picture, or you can have spider veins, varicose veins, which are the bulgy veins on the surface, edema or swelling, especially seen at the ankle and in the lower calf, hyperpigmentation, which means discoloration of the skin, and actually hyperpigmentation can happen first, and then the skin can become very leathery. And then on the far side, we have an ulceration, which is a non-healing sore of the leg, and it doesn't heal well because the leg isn't being drained well. And when that happens, it's very difficult to either cure an infection or to get anything to heal because of the swelling and the poor drainage from that site. So symptoms of veins that aren't working properly or venous insufficiency includes the varicose veins, as we see here, the darkened, hard or leathery skin and swelling. But you can have symptoms of pain and heaviness, leg cramps or spasms, especially that can awaken you at night. Restless leg syndrome, also seen frequently at the end of the day. And restless leg syndrome, has become pretty commonly known today, and there's medication for it, but about 40% of it can be reversed by treating vein disease that might be the cause. And then itchy skin is another one, and even rashes can occur because of the vein problems. So the causes of varicose veins are many, but the most important one is heredity. And then secondly, gender, because women do have more of a preponderance to get varicose veins than men. Race, the Caucasian race has much more varicose vein disease than other races do. Trauma, if you get hit in the leg when you're a child, you may actually rupture a valve in that vein. And then in later life, that can lead to problems because if you've got one valve that doesn't work, it can lead to a sequence of valves below that stopping working because they're overloaded and the vein dilates and pulls the valves apart. Phlebitis, which I was explaining, if you have slow blood flow in a vein, then you can have a clot form, and that can actually lead to more problems with varicose veins. And then age, because as we age, we lose collagen production, so the vein wall isn't as strong, and so it can stretch out, and that's the major cause of varicose veins in men. Aggravating factors include multiple pregnancies. So if you have a tendency toward varicose veins, something that may definitely bring them on would be having multiple pregnancies. We often hear that it's that third pregnancy that really leads to those veins being there permanently for somebody. Hormonal influences that can be seen as we get older, excess weight, strenuous weightlifting. So people who do a lot of weightlifting are putting a lot of back pressure on their veins. If they're doing that Valsalva maneuver where they're holding their breath and straining, that's the worst thing you can do. It's why usually if you have a coach, they're telling you when you're lifting something heavy or when you're doing a strenuous part of an exercise, that's when you should exhale. Because if you're holding your breath in an inhalation, you're putting a lot of excess pressure back on those veins and it can rupture valves. The occupation you have or your lifestyle. So if you stand for long periods of time, like women who are hairstylists, nurses, surgeons, or people who are sitting at desks all the time, secretaries, or nowadays we're all sitting in front of a desk a lot more because of our computer lifestyle. those things prevent us from walking and using our legs and using those calf muscles to empty the legs. And so that can also lead to more problems with varicose vein disease because everything's getting backed up. And poor posture can also be a problem that can lead to more varicose veins. So now when we evaluate here, this is my clinical team who I want to introduce you to. They're hiding their faces, as you see. But from left to right, we have Jen, who's one of our certified physician assistants, then Lisa, who's also a physician assistant. Then to her left, and the next one on the right is Lisa, who is a nurse practitioner, family nurse practitioner, and then Jane, who's also an adult and geriatric primary care nurse practitioner. So we have all advanced practice clinicians as our medical team. And these nurses and PAs are very skilled, both in the evaluation and your initial consultation as they meet you for the first time, but also in doing these procedures. And so although I do all the procedures involving any kind of laser closure, some of these people will always be helping me or might even be doing some of the procedures on their own. When we do an evaluation, we do a pretty thorough one here. So first there's the matter of getting a history, and we obtain your general health history, and then we talk to you about the symptoms that you might have, get a little bit about your occupation, what kind of work history you have. For women, we ask about pregnancies, and we also ask about family history because it is important to know sometimes in making a decision of how much more we should investigate if we don't see varicose veins, but somebody has a lot of symptoms and a strong family history, then we might go further with some of the evaluations. Then we do a physical examination where we look at the leg, feel the veins that are on the leg, do some measurements, take photos, which we have to have, do a classification that is a kind of an international way of classifying vein disease. And we also give it a clinical severity score based on what the veins look like and what kind of symptoms somebody has. And then finally, we do our ultrasound study, which is the most important way we diagnose varicose veins disease today, and which has made it a much better way of treating varicose veins because ultrasound will show us exactly what's going on in the legs. We do ultrasound with the person in their standing position because we do want to see the effects of gravity on your legs. And so as we're standing, it's the best way to see that. The ultrasound is done to evaluate both the deep and superficial veins. Then there's an ultrasound interpretation that I do when I come into the room, and I recommend a course of action for somebody at that point. Now, I'd like to introduce Rebekah Coulthurst, who is your main liaison in all of this. Hi, Rebekah. Okay, so Rebekah is our billing and coding specialist, our vein procedure scheduler, and our liaison with the insurance companies. So she's the one who will be contacting you about any questions about insurance. She's going to be letting you know once we've heard from the insurance company and really giving you all the details. And she is your best friend to have because she really goes to bat for everybody if there's a problem with insurance coverage. And so she is the person who we rely on tremendously for getting all these things accomplished. And then I just want to show another member of our team. I call Rebekah and Marcia our indispensables. Marcia is our sonographer. She's the person who does the ultrasound examinations, and she's in every single procedure where we're treating any kind of varicose vein disease involving the trunk veins of the leg. And then Rebekah is on the right, and she again is the person who you can contact with any questions once you've seen us. Now, there are insurance requirements that we cannot avoid that may determine how long it is before a treatment can be done after we meet with you. Now, some insurance companies actually require that you wear graduated compression hose as a trial before we can even request any kind of authorization to proceed with treatments. And they may be required for as little as 6 weeks or up to 3 months. There are a couple of insurance companies that no longer have a graduated compression hose requirement. And we like working with those companies for the patient's sake because it's a lot easier to get approvals quickly and to go ahead and schedule something if it needs to be done. But we have no control over the insurance rules. It really depends on your policy and who your insurance carrier is as to whether or not you have to wear stockings ahead of time as a trial. Once we have determined, what the problems are, and we feel that an ultrasound may be necessary to really give us the kind of a roadmap of the leg, It's called a duplex ultrasound. And this identifies any abnormalities in the wall of the vein, which may be acute or chronic phlebitis or thrombosis, clots that may have been there and have caused scarring, whether or not there is a problem with the valves being competent or leaky, and then any anatomic variability. We actually have seen people as early as their young teens who have a problem with varicose veins because there may be an artery crossing in a funny spot over a vein or some other anatomic variability that we need to know about before we can address doing any kind of procedures. The duplex ultrasound examination is a painless study. It's performed, as I said before, with persons standing. And if anyone has ever had a pregnancy, they know an ultrasound is a painless study. There's just some gel involved, so you get a little messy. We provide paper shorts as long as we have those available. Of course, there's been a shortage of all kinds of disposable garments and masks and things over the last several months. So we may ask you on occasion to have to bring your own loose fitting gym shorts, but otherwise we provide you with the shorts, and this allows us to do an examination of the entire leg so that we can see what's going on with the veins and really get a good picture of it. When we're doing the ultrasound, or when Marsha's doing the ultrasound, she's tracing the reflux. So that's that backflow in the blood vessel, in the vein. She also notes the size of the saphenous vein or the small saphenous vein and the presence or absence of reflux at several points along the vein. All these things are required by insurance, but also give us the opportunity to actually make a diagram of what's going on in the veins of your leg. Pathologic or abnormal reflux depends on which vein we're talking about, but has certain amounts of seconds assigned to it. So for instance, in the great saphenous vein trunk or in the small saphenous vein, a half a second of reflux means the blood is going backwards for half a second. We usually see it for much longer than that. And the time it takes for the valvular reflux to close is what we're looking at. And so in this lower picture, this is where we kind of do a compression on the leg, and then we're seeing how long it takes for this blood flow to come back down to normal. And that's a long one, of probably of at least 2 seconds. And that's not even at the end of our monitor there. So it's not uncommon for us to see reflux that's longer than 4 seconds long. When that happens, we know that those veins are not working properly, and it certainly explains why somebody's having symptoms of congestion in their leg. Now, in this picture, I'm just showing what we see again with the waveform. We put a little cursor on this area of the vein. This is the vein here in the longitudinal fashion, and we compress, and then we see how long it takes for this Doppler or sound wave to come back to normal, so we know how long the reflux is. Sometimes it may not be necessary to do an actual procedure, or sometimes people want to look at other options. And there are a couple of things that are options that we can discuss. One is a supplement that contains flavonoids, which are things that are found in grapes, but specifically for veins, it's something found in the rind of bitter oranges. And it's diosmin, that's the flavonoid that actually may help strengthen veins. And this is a medication or a supplement that we carry in the office. It's pretty inexpensive. It's less than $35 for 60 capsules, which is a 2-month supply. And really, Vasculera is the medical form of that. Vasculera is the first what is called prescriptive food ever approved by the FDA. So it's not considered a medication, but you do need a prescription for it. And we only can get it from an online pharmacy because they're the only ones who will give us the patient any kind of reasonable pricing. If you try to get this from a pharmacy around here, you might be spending $1,000 a month. Whereas through the online pharmacy that we use, you get it for anywhere from $45 to $49 a month, depending on whether or not you get a 1-month or a 3-month supply. And it works very well to help reduce swelling. And we often use it in people who have a lot of varicose veins and have them start taking it for 2 weeks ahead of time before a procedure, because it's going to help them recover more quickly after the procedure with less swelling. So when we look at doing a procedure, a minimally invasive procedure to get rid of varicose vein disease, what our goals are is, number one, symptom relief. We want to get rid of your aching and throbbing and your fatigue and get rid of the itching of the skin you have, and reduce or get rid of the swelling and restlessness. Our second goal is very rapid recovery. We don't want you to have to be lying around for any prolonged period of time because that increases the risk of complications. So you're able to walk in and walk out about an hour to an hour and 15 minutes later after the procedure is over and go back to normal activities. The next day, almost everybody's back at work. We also want to get a cosmetic result. So that means no more bulging veins. And there are imperceptible scars. These are little pinpoints. Everything we do is done through nothing larger than a needle, a little hypodermic needle. And so therefore there's imperceptible or no scarring that's ever seen after things are totally healed. Now, the methods we use when we are treating venous disease, when somebody has reflux in their great saphenous vein that is considered pathologic and somebody has symptoms, the main thing we do is endovenous laser ablation. Endovenous laser ablation is done through a little tiny laser fiber that's inserted in the vein through a numb spot after when we're doing the procedure. And the laser fiber is about the size of a raw spaghetti in diameter. So it slides right up the vein. And then I'll talk about that procedure in a little bit. Other options include something called Varicose. Now, Varicose is the first commercially available medical foam that we can inject into a vein to get the vein to go into spasm and close off. And Varicose is made, it's supplied so that we actually activate the canister with compressed air, and it's oxygen and carbon dioxide is the compressed air, and then we can inject it. Similarly, we can make an ultrasound guided injection of a medication that we call a chemical ablation, again, using FDA approved medication that we foam ourselves in the office by bubbling it up through a stopcock so that we can make a foam. So when Varicose is not allowed by different insurance companies, or when it's a smaller vein, we may just be doing an ultrasound guided chemical ablation ourselves. Phlebectomy is where we actually remove the vein through little tiny needle punctures, and sclerotherapy is where we do injection of a medication into the vein to get it to go into spasm and close off. And as you see, I have little hypodermic syringes at 3 of those places because everything's done just through little needle punctures and nothing more. The laser also is put in just through a needle. So ultrasound is important not only in diagnosis, but also during the procedure. And this is what has made treatment of varicose veins so much more not only accurate, but safer as we have come to this new era of treatment. So the procedural use of ultrasound during the procedure, if we're doing either an endovenous laser closure or we're doing Varicose or an ultrasound guided injection, we use it as a guide to select the entry point of a needle to place the device through the needle. And so we're using ultrasound at all times to look for that. And we also use the ultrasound to actually see the laser fibers. I'm feeding it up into the vein, or if we're seeing the foam approach the area where we want it to go, if we're using Varicose or the chemical type of closure. We also use it to guide the deliverance of our anesthetic. So as we're doing these procedures, everybody's going to be very comfortable because we're injecting a very dilute anesthetic around the vein so that you have no discomfort at all during the procedure. And we use the ultrasound to make sure that we are getting circumferentially around the vein when we do that. We also use it to evaluate the treated vessel immediately after the treatment. And we use it to assess the deep veins afterwards to make sure that nobody has a problem with any kind of clots that can occur. And we want to also use it to provide follow-up as necessary. We always do a follow ultrasound at about a month after any procedure so we can make sure that the veins we closed are staying closed. So to talk about this first treatment, the endovenous laser therapy, what we do the day of the procedure is we mark your leg using ultrasound, and it shows us just where the vein is. Then we use a little bit of local anesthetic just through a little tiny injection to numb the skin before I go through that numb spot with a needle to allow into the vein. And using ultrasound guidance, I'm able to thread the little laser fiber up inside. Then we anesthetize everything. Then we activate the laser, and only the very tip of it gets hot. The rest of it has a coating on it so that Nothing's injured except what we see at the very tip of the laser as the laser is being withdrawn. And I withdraw the laser at about 1 to 2 millimeters a second. So the total pullback time ranges anywhere from 3 to 6 minutes, depending on how long the segment of vein is that we need to close. And again, that's a totally painless procedure. And this is just a diagrammatic illustration of the laser fiber is inserted in the vein. It's much smaller than the surrounding vein, so it slides right in. And then as the laser fiber is activated and we are pulling it back, we're closing the vein from the top down. And then we just see on the far right, a closed vein following the treatment. And this is just, again, another diagram of the injection of Varicose that we can see here. We're using an ultrasound probe to see where we're going to inject. I inject and this foam comes out. It actually travels up the vein and we are ready to compress up above to stop the foam from going any further than we want it to. And it causes severe spasm of the vein. So it starts like this, it ends up like this. And with the foam in place, it irritates the inner wall of the vein so that that just doesn't work any longer, so the vein stays closed. Our success rate with these procedures, 95% with the Varicose, 99% or better with laser ablation, and they're very good techniques, as good as or better than the old vein stripping. And the reason they're better is because we actually see the veins we're working on the whole time with ultrasound. So we know exactly where we are, and we don't miss any secondary vein or duplication of a vein or bifurcation that could have been missed with the old method of vein stripping. Now, the reported side effects nationally are anywhere from 0 to 15% for these procedures. We see less than that. And when I'm saying side effects, I'm talking really about minor side effects, meaning people are going to have bruising. When we're taking out some varicose veins, they may have some bruising, but very little bruising is ever seen when we're doing Varicose or the laser ablation. With phlebectomy, removal of varicose veins, there might be a little bit of lumpiness left behind that goes away, gets absorbed by your body. There can be a risk of 1 in 10,000 of infection at a puncture site, but the side effects per se, meaning any discomfort, pain that you might have, or redness, irritation, is really mild and it goes away usually totally within 2 weeks if you have it at all. Now, the one major complication that can occur that we're always careful about and we search for in the postoperative period is a deep vein clot. So as I said earlier, the saphenous vein, the small saphenous vein, not only have connections along their course with the deep system, but then they enter into the deep systems at the apices of each of these veins. So the popliteal vein behind the knee is where the small saphenous vein enters, and the great saphenous vein enters into the common femoral vein in the groin. Those are called deep veins. And the laser and any kind of heat process that's used to close the vein causes clot to form. That's normal. But we, using ultrasound, we're able to position the laser so it's about 2 centimeters down from the junction into the deep system. When we do that, we have seen really no clot extending into the deep vein, but it can happen. And so there is always that risk. And if that were to happen, and it's considered to be less than 1 in 1,000, but we've done probably 12,000 of these procedures and not had any that have gone into the deep vein with any kind of consequence. It would have to be obstructing the deep vein by about 50% before any treatment would be necessary. And luckily, treatment today is oral. You know, there are the new oral blood thinners that are the treatment of choice for any kind of blood clots in the leg, in the deep system. And so it's a much easier way to treat something than it might have been even 10 or 15 years ago, because we now have blood thinners that are very easy to use. Now, if we go on to actually removing the varicose vein, which is a little closer to the skin and is bulging through the skin, we're doing a procedure called microphobectomy. And that involves just making a needle puncture. Through that needle puncture, I use a micro hook, kind of like a little crochet hook. And we're able to, by feeling around, find the vein and kind of pull it out through that little needle puncture. The vein's all been collapsed down by the anesthetic we're using. And then we're able to remove the vein in segments. So we can remove it from each side by just pulling a little bit in each way. to get that varicose vein out. And we just work our way down the leg wherever we have to. And it may be a series of just a few punctures. It may be 20 or 30 punctures, depending on how many varicosities somebody has. And then the last thing is sclerotherapy. And sclerotherapy is where we inject, again, an FDA-approved medication into the tiny little spider veins of the leg and into what we call the feeding veins or the reticular veins, which I've demonstrated here with this arrow. That's a reticular vein. It's a little bit larger blue vein under the surface. And then you can see these little smaller veins, which are the spider veins. And so in order to get rid of the spider veins, we have to inject the reticular vein as well. And spider veins can cause symptoms, and people sometimes get concerned when they have symptoms from spider veins because they can have swelling and itching and throbbing of these areas, restlessness or crawling sensation. And these spider veins most commonly occur on the leg, but can also occur on other areas of the body. The face is the next most likely, but these are very tiny veins that can be treated. However, they are considered a cosmetic issue. Insurance companies do not allow spider vein treatment to be covered by insurance. So the causes of reticular spider veins can include varicose veins, hormones, trauma, collagen vascular disease such as lupus or scleroderma or other things, or genetic and congenital factors. And to be honest with you, 75 to 90% of women will develop spider veins at some time in their life, and you cannot get rid of them permanently. We can get rid of the spider veins we treat permanently. However, you will develop more spider veins later in life. And so there's always a way we can treat them, but you just have to know that the spider veins recur and can continue to occur the older we get. And here at Wisconsin Vein Center MediSpa, we do a combination treatment for spider and reticular veins. We first use a little surface laser, which has just a little pinpoint laser. It's only a 0.5 millimeter to 1 millimeter in diameter for the laser that we use on the surface of the skin. And we just trace out the spider veins with that. And then we inject the spider veins and inject those reticular veins that I showed you. It's going to take an average of 1 to 3 treatment sessions to achieve 80 to 100% clearance without those veins ever coming back. And the treatment is followed by 5 days of compression stockings. In the summertime, we might let you go down to 3 days, but you need some time with compression stockings to help keep these little vessels closed. So I'm just going to show you some before and after treatments of varicose veins that we've done, again, using our minimally invasive techniques. And these are unretouched photos. And then some spider vein treatments that we do as well. So as you see, we can get some very nice results for these treatments, very good cosmetic results as well. And the last thing I just want to mention is something called lymphedema, because lymphedema is a problem that can start with venous disease, but may also start with your lymphatic system, which is the third set of vessels in the body. You've got arteries, veins, and lymphatics. Lymphatics are the smallest vessels in the body, and they actually start out just as little strands located between cells. And so what happens when you have venous congestion of the leg is that the higher pressure is located at the ankle. And when you have high enough pressure, the veins aren't that strong, and so fluid can actually leak out of the veins. When that happens, there can be a high protein load in that fluid that may be too much for the lymphatics to help drain. So you can get swelling that becomes more of a chronic problem. Once you've overloaded the lymphatics and destroyed the lymphatics, we may not be able to reverse all the swelling that you have in your leg by fixing the veins. The good news is this is more of a congenital problem. The most you would ever see with what we call phlebolymphodema, meaning venous lymphedema, would be at this kind of stage. And the treatments really have come a long way. I would say 5 years ago, there was very little that could be done for lymphedema except a compression around the leg using kind of a stiff bandage. or some lymphatic drainage that could be done by a specially trained technician or massage therapists. And nowadays there can be combination treatments that can be done. This is a wrap that we have prescribed to many people. It's called a Ready Wrap. And it's just something that has little Velcro tabs, very easy to put on. You don't have to stretch it much because it's pretty non-flexible, but by having that kind of stiff, stiffer, very comfortable wrap on the leg, it really keeps the swelling from getting any worse. And then this kind of thing, which can go the whole length of the leg, actually can have an attachment of a pneumatic compression device that we use at home. So people at home can, for a couple of hours a day, can lie with their legs elevated and have compression doing sequential pneumatic compression like you might get in the hospital after surgery, but it's the whole length of the leg to help really treat lymphedema. So in conclusion, I would say that varicose vein disease can be managed using minimally invasive techniques. And although we can't cure varicose vein disease, it can be controlled and may not need any further procedures during your lifetime. So thank you for your attention, and I'm very happy to answer any questions that you might have.
It looks like we don't have any in the chat, but we did have a few prior to the webinar.
Okay.
Why the stand-up ultrasound? Somebody wants to know.
Okay, we do a standing ultrasound because, again, we want to see the maximum effects of gravity. And if you're standing, that's when we're going to see that. So one of the things that you do have to know about any of the treatments that we can do minimally in a minimally invasive fashion is you have to be ambulatory. We can't do this on somebody who is bedridden or who is not able to get up and walk, because there has to be an active participation of the person so that the muscles are contracting in their leg and helping to empty the veins. But we do it standing, we do the ultrasound standing so we can see the effects of gravity. We can really see if there's reflux going on. And it's a mandated type of procedure when we are evaluating venous disease in the superficial system, at least, that somebody must be standing.
And one of the other questions is there a best time for treatment when it comes to that? You know, what is the time frame depending on if it's a spider vein treatment or a varicose vein treatment?
You know, there's not. I mean, a lot of people want to get their spider veins treated for cosmetic reasons. And so this time of year is a great time of year to get ready for summer when you might be exposing more of your legs. And so it would be a great time to do it. I can't say that treating spider veins prevents you from getting varicose veins in the future. So, you know, if that's the kind of timing they're asking about, no. But if you're having any symptoms, that's the time to really have your varicose veins evaluated so we can see if we can do something to treat the varicose veins. And spider veins, totally, both of these things are elective unless you've had a major complication from in your veins before we ever see you. But these things can be done in your own time frame. This is, again, a great time of year to do it. The closer we get to the end of the year, the busier we get here because people are looking at their insurance plans and they see that they've fulfilled their deductibles, and then they say, oh, I've got varicose veins, maybe I should get them taken care of now. But sometimes we need those extra weeks because of your insurance requirements. So it is much better to be seen as early as you can in the year to get this started.
Okay, we did have someone just ask if you didn't have insurance. What happens then?
Okay. We have out-of-pocket pricing. We actually do have a whole section of society who we treat that has no insurance. We cannot treat people who are on Medicaid because I do not have a license in the state any longer to do the Badger Care or Medicaid patients. But for instance, if somebody doesn't have health insurance or has a high deductible, so they don't want to go through insurance or there's no need to, then you talk to Rebekah after we've done the evaluation. I tell Rebekah what the procedures are that are needed, and she will give you what the pricing is for out-of-pocket costs for those procedures.
Okay, and there was a question about Medicare covering the procedure.
Yep. Medicare will usually cover the procedure. Believe me, we have all the rules for every insurance company and Medicare that Rebekah updates for us 2 to 3 times a year. So as you see, it's multiple pages we have to keep up with because every insurance company has their own rules. And so we do keep up with what coverage is allowed. And Medicare, if somebody is symptomatic and we have demonstrated problems in the veins with ultrasound, then those procedures can be covered by Medicare.
Okay. And I know you mentioned compression hose in the previously. Yes. In fact, as you all can see, Dr. Manjoney is very thorough and it explains everything so we can all understand it. But I did want to clarify with the compression hose. Somebody's asking about the time frame for that. It's different for each insurance company.
It's different for every single insurance company. And so, Rebekah can tell you if you do have a question about that. Medicare is 6 weeks. And so, if you don't have an appointment right away, go ahead, come in, get measured, get your stockings so you can start on that process that we can fulfill. We fulfill every insurance company's requirements to the letter. We can't treat spider veins and charge insurance companies unless you're bleeding from a spider vein. That's the only time we can. So other than that, it is considered a cosmetic procedure, and we do have pricing for that. For cosmetic procedures, we do a lot of sclerotherapy cosmetic treatments, and those are all done by my clinical staff that you saw pictures of, Lisa, Jen, and Jane. They're excellent. They do several a day. It's fast. It's not painless, but at the most a little bit uncomfortable. It is not something that you should dread by any means.
Right. So if someone's looking to do the compression hose, they need to take that in consideration when they're talking about a timeline that they want to have.
That's right. Although we can see you in consultation and even get your ultrasound done and talk to you about the compression hose so that, you can get started and know exactly what you might want to have to expect from a procedure standpoint, even if you haven't fulfilled your requirement yet for the compression hose. And then we just make sure, that we document that we have seen you and talked to you again at the end of that compression hose trial period, and so that we can submit it to insurance.
And everything is done in office.
Everything's done in office, and everything's done just with local anesthetic, which means injecting of a numbing medicine into your skin. It's a very dilute anesthetic. It has a little bit of epinephrine in it. And the reason I'm saying that is because that's what makes this possible to be done in the office, because there's almost no bleeding at all. The epinephrine makes the veins go into spasm. So that's why we can take out huge varicose veins through just little needle punctures. And it is also why there's minimal bleeding involved with any of this, because the veins are pretty much emptied out, because as they go into spasm, the blood's out of them.
I think between the chat and the Q&A, we've covered all the questions. Was there anything else that you wanted to share before we?
Not really. I just wanted to, again, thank people for attending this. And if you do have questions, you can reach me or ask us questions at info@wimedispa.com, or call us on the main number, and the calls can be transferred to our nurses or PAs. And if there's any further question, I can answer them. We obviously can't give you any medical advice without meeting you, but we can certainly answer questions that you have about, do you need an evaluation, or what the evaluation will consist of. And you can also go to our website to see more about varicose vein disease at wimedispa.com. So, we'll leave that up for a little while so you can write down that information if you would like. But we would be very happy to try to, address any issues that you might have.
And we are recording this session. So obviously, if you couldn't make it, you're not hearing this. But if you want to go back and watch it again, we will be sending that out in the next few days. So you can keep an eye open for that. If you have any other questions that you didn't get to answer, ask in the chat or the Q&A section, like Dr. Manjoney said, feel free to email us at info@wimedispa.com or give us a call. And we did have somebody reiterate in the chat, I'm seeing that, yes, we do sell compression hose and we can measure you here. So
yes, we can.
That's something we do here. So it's a one-stop shop for all your vein needs here.
And it's something that I really enjoy doing. I will tell you that people are very happy after this procedure. I will tell you, if anyone's nervous at the time of the procedure, we have a few that are, they, at the end of it, they're saying, oh my goodness, I was anxious for no reason. This was not at all what I expected. We do try to make you as comfortable as possible. We have music playing in the room. If it's wintertime, we put little warm booties on your feet so that you're comfortable. We do try to do everything we can to help you relax. We can talk to you while we're doing the procedure. You can talk to us. There's no problem. You're not interrupting anything. You're not distracting us with questions. About half the people wish they could watch, which they can't, unfortunately. And about half the people say, I don't want to know anything about it, so don't tell me too much. But we always, try to take everything into consideration to make sure people are as comfortable and as informed as they wish to be.
We had somebody ask, can we have wine?
Sometimes we do.
No, but I can attest, I've been here for a number of years, and I can attest that, every single one of our clinicians that you would see, from the ultrasound tech all the way to the PAs, the nurses, Dr. Manjoney, they're all fantastic. I've heard clients over and over just rave about the treatment that they have, the kindness, the caring, how attentive they are. And also, I see a lot of the before and after pictures, and I have to say it's impressive. So if you are worried about it, if you're scared, if you don't know, I don't know about all these new people, you have nothing to worry about. I can assure you that Dr. Manjoney is not just speaking highly of her clinicians because they're her clinicians. As a patient as well as an employee of some of these gals, everybody treats you with respect and is very good about giving you all the information you need so you know what to expect for every treatment. So
don't hesitate to come in and meet us in person. There's no commitment of any kind. It's just, we can tell you what we can do. I'll be very honest with you. If it's not a vein problem, I'll explain that to you, because other things can cause pain in your legs. But if it's something that I think we can help you with, I will let you know exactly what we can do to help you. And then we go through all the procedures. With Rebekah's help, I have to write a letter to the insurance company that goes into the insurance company. When she hears from them, she will call you and let you know what's been approved. Occasionally, if something's not been approved, I may do what's called a peer-to-peer review with the insurance doctor to try to get them to reverse their decision. And then once we have all that information, Rebekah also formulates a letter for you that has what your out-of-pocket cost will be, whether or not you still have a deductible on your insurance plan, whether there is a copay involved, so that everything is really laid out as clearly as we can. We want to keep everybody as informed as possible, no surprises, and really try to achieve the absolute best results possible.
Yeah, and that is definitely something people are very impressed with. They kind of get to sit back and we handle it all for them, and we have all the answers, and they know ahead of time what's going to be out of pocket and what their insurance will cover. So that's definitely something that we kind of sets us above the rest. We do have a couple other questions that have strayed in. How long are the consults?
The consultation is about 45 minutes. During that time, you'll meet first with one of my mid-level providers, and they'll take the pictures and ask some of the questions. Then I'll come in and I'll go through your history again, especially your symptoms of venous disease, because there are things that I do pick up that, sometimes after you've been asked the question the first time, if I ask you again, I may either lead you in a little bit different direction, or you may have thought of something that you want to tell us. And so, I go through kind of at least your vein symptom history again and look at and examine your legs. And then that's it. So it's about a 45-minute appointment in total. It is quite thorough, but you can be sure that you're going to be out in 45 minutes. There's really very little that we would do that would increase the time of that. If you're coming from a long distance, we like to know that ahead of time, because then we can ask, our front staff might ask you a few more questions on the phone, because if you truly have the bulging varicose veins, then you'll be offered a possibility of having an ultrasound the same day. Otherwise, we don't do the ultrasounds the same day, because we need to be able to make a decision whether or not you need one. And so, if we're not sure if you have varicose veins or exactly what your leg problem and discomfort's from, we don't automatically schedule you for an ultrasound. But if you are coming from a long distance, we will try to accommodate you in any way we can. And so we then often will try to do the ultrasound the same day.
So we did have a question too about the cost of consults. I do want to reiterate with people that you can call your insurance. Actually, you can call us and find out what our what's the number, Dr. Manjoney. I'm trying to think of that they to check with their insurance to see if we're in network. Their tax ID number, correct?
Tax ID number, but we are in network with most insurance companies. I will tell you that. And so it would be very rare, unless you have an unusual one for Wisconsin, that we're not in network. I don't think we're in with Aetna. Other than that, we definitely have contracts with most of the other insurance companies. So the cost of the consult would be covered by insurance, or it might go toward your deductible if you have symptoms and a medical reason. For spider veins, since it's considered cosmetic, and if you don't have any symptoms or the symptoms are just localized to the spider veins, if it turns out to be a cosmetic consult, there is a $100 fee, which is then applied to your first treatment. And so, you are just basically paying a little bit ahead for the cost of your first treatment. And that's just in case people don't come back, since it is a 45-minute appointment, we're collecting some of that money up front.
And another last minute question, do other veins take over when varicose veins are gone?
Absolutely. That's what the superficial veins have a real network underneath the skin. It's almost like a fishnet stocking. There's so many superficial veins in the leg. And sometimes it seems counterintuitive that by closing a vein, we're improving the circulation, but we are. Because if you think of having a blockage in a pipe and, the high pressure that's behind that blockage, that's not going to help any of the other pipes that are around, anything that's bridging off from it. But once we get rid of that obstruction or close off that pipe that's not working, if the other pipes are connected to other things, they're going to become much more efficient in their drainage. And so that's what I try to explain to people. These are the veins we're talking about potentially closing or removing parts of are veins that we in the past have used for bypass surgery, like when I used to do coronary artery bypass surgery. But if people had dilated abnormal veins because of varicose veins, those veins aren't usable for bypass. They're too big and abnormal to meet the small size of the artery on the heart, and so they can't be used. So you really don't have to worry about these veins being taken for any medical purpose, or if they're, if you think that they're going to impede any circulation problem, it's actually going to improve it. It improves the efficiency of the veins that are there because they're not fighting this backflow and reflux into the leg.
Okay, well, I think that wraps it up for questions.
All right. Well, thank you, everybody, and I hope you have a nice rest of your evening. And again, thank you so much for your attention and for attending here tonight.
Thank you so much, everybody. Bye-bye.